Hello everyone, I'm Ulrich Sidney. I'm the founder and president of the Association of Future African Neurosurgeons. Today we're going to have a session with two of our members, Devin Sichimba and Zolo Ivan, both medical students. Before we start with the presentations, we'll go around and introduce ourselves. So we'll start with Dr. Regis. Dr. Regis, can you present yourself, please?
Okay, hello everyone. I'm Regis, Cameroonian and Ivory Coast program resident in neurosurgery, first year. Nice to meet you all.
Nice to meet you, Regis. Thank you so much for being here. Next up is Dr. Kabulo. Dr. Kabulo, please, can you present yourself?
Hello everyone, my name is Kabulo from Democratic Republic of Congo. I'm a resident in neurosurgery at the University of Zimbabwe.
Thank you, Dr. Kabulo. Dr. Satrio Sasono, do you want to present yourself, please?
I don't think he has a microphone.
Okay.
So you better, okay.
Next one will be Zolivan. Do you want to present yourself, please?
Hello everyone, I'm Zulu Ivan. I'm a medical student from Cameroon and a member of the Association of Future African Neurosurgeons. It's an honor and pleasure to be here with you.
Thanks, Zolo. We weren't really able to hear you. I think it's because of the microphone. So when you'll be presenting, maybe you get it closer. Okay, thanks. And finally, Delwyn, before Delwyn, Dr. Kartik, do you want to present yourself, please? Or maybe not. Okay, no worries. We're going to start. Delwyn, you can present yourself and we will start sharing the slides. And John, please, if you can mute everyone, that would be very helpful.
Okay.
Thank you very much.
Hello everyone, I'm Darwin Chimba, medical student from Copperbelt University of Zambia. So today I'll be presenting on the red flags of spinal disease. So before we go into the presentation, we want to look at the outline of my presentation. So I have the introduction, the basic anatomy, the risk factors for spinal disorders, etiology of spinal disease, the red flags themselves, which is the main concentration of my presentation. Then you have the approach to a patient with red flags, conclusion, then references. Okay, so on my introduction, among the wide spectrum of diseases treated by neurosurgeons, a few are as gratifying as a good outcome, like freedom from pain or disability in a well-selected patient with a spinal problem. So in other words, what we're trying to say is that among the other problems that are solved by neurosurgeons, one of them is spinal diseases, and it's usually a good outcome is something that is usually needed in such a case. So spinal surgery comprises a major part, often about 70 to 80% of the practice of most general neurosurgeons currently practicing in the USA and many other countries. So it's quite a big component of neurosurgery worldwide. So as we look at the older population, in the older population, or rather when we have older patients presenting to our health facilities, what we find is that the older the population, the more people with falls and fractures. So we find that when people tend to age, when people start aging, a lot cases of falls fractures because of age, and also other diseases that start coming in due to age. Then other than that, as patients grow older, we find that they have more tumors. There are more tumors in patients who will live longer due to advances in oncology treatment. So these patients, we know that also certain cancers, they begin to develop more in older patients. When people tend to grow older, these people, rather these patients, they become prone to certain types of cancers. But with advancement of oncology treatment, these patients still tend to live longer. And because they tend to live longer, they start presenting with neurosurgical disorders, including those of the spine. Because like we have said, like I have mentioned that as they grow older, they begin to present with problems of falls and fractures. So even these patients who have tumors but they tend to live longer, they are going to be presenting with similar problems. Then we also see that as patients grow older, as people grow older, they begin to develop more degenerative pathologies or other disorders. So now, as a result of this, more demand to perform procedures to help these patients improve their quality of life. Okay, so because of the increase in the incidence of these disorders, there is need, or rather there's demand to perform more procedures to help these patients improve their quality of life. So we can't just let these patients be because they're presenting with these disorders and all, but there's much more need of performing these procedures, and also there's need for education and training of neurosurgeons in such areas. Then the purpose of this presentation is to highlight and discuss the red flags of spinal disease. However, it shall also encompass a few other relevant areas of the subject. And so other areas like anatomy of the spine, just some brief anatomy. I will not go so much deep into that. So basic anatomy of the spine. Okay. So the vertebral column, which is also called the spinal column or the spine or backbone, okay, invertebrate animals, including human beings, is the flexible column extending from the neck to the tail. Okay, and it is made up of a series of bones which are called the vertebrae. So in the human vertebral column, there are 33 vertebrae, which are divided into cervical, which is from T1 to C7, thoracic from T1 to T12, lumbar from L1 to L5, sacral from S1 to S5, and these are usually fused, especially in older patients, and the coccyx, which is made up of 3 to 5 segments. So both the cervical and lumbar spines, they demonstrate lordosis, which is inward curvature. Okay, then the thoracic and the sacral, they demonstrate kyphosis, which is outward curvature. So not lordosis or kyphosis in terms of a disorder or in terms of the disease, but it is just some minimal inward curvature and outward curvature respectively. So in this part of the exoskeleton, which is this spine we're talking about, okay. So this part of the exoskeleton is the one which protects and the neurostructures and internal organs. So we know that this spine, through the spine, or through the vertebral column, we have the spinal cord, as well as the spinal nerves, which are branching off from there. Then other than that, we also find, especially in the thoracic region, we find that there's attachment of the ribs, which are going to be protecting the thoracic cavity organs. So the line of gravity of the human body passes through the auricle of the ear, odontoid process, a body of C7, anterior to the thoracic spine, then posterior to L3 and mid femoral head. Okay, so the spine is the axle bearing of the load. of the head, shoulders, and the thorax. The upper body weight is then distributed to the lower extremities through the sacrum and pelvis. This reduces the amount of work required by spinal muscles and can eliminate muscle fatigue and back pain. Okay, so that diagram is simply showing the basic regions of the spine. So the first region, which is from C1 to C7, we have the thoracic region. Okay? Then from T1 to T12, we have the cervical region from C1 to C7. Then from T1 to T12, we have the thoracic region. Then we also have the lumbar region from L1 to L5. Okay, and then we also have the sacrum. So all those diagrams are showing. The other diagram on this slide, on this particular slide, it's also showing the developmental stages of the spine. Okay, so you can see that the characteristic curvatures of the adult spine appear over the course of the postnatal development, being only partially so the newborn has a kyphotic spine curvature, okay, as seen is in part A of that diagram. The lumbar lordosis, okay, develops later and becomes stable at puberty. So as we can see in part C of that diagram. You can go to the next slide. Next slide. Okay. So let's look at the risk factors for spinal disorders. Okay. So some of the risk factors, they may not just be these ones alone, but some of the risk factors that we can look at that can increase the risk of developing a spinal disorder include obesity, improper lifting of lifting techniques, nutrition and lifestyle, occupation, and diseases such as osteomyelitis, rheumatoid arthritis, or thyroid disease. Okay, so those are some of the risk factors for developing spinal disorders. Okay, so what are the causes of spinal disease or spinal disorders? So these causes of spinal disease, they are broadly classified as follows. That is, we have trauma. Okay.
Freaking asshole.
So we have traumatic causes. Sorry.
John, please, can you mute yourself? Go ahead, Darwin.
All right. Okay. So I was talking about the causes of spinal disease. Okay. So these can be classified as traumatic, congenital, inflammatory, hereditary, and degenerative, as well as those which are idiopathic or the unknown causes. Okay, let's go to the next slide. Okay, so this table simply shows more like the differential diagnosis of lower back pain. Now, among these, we have most of them spinal disorders. Okay, so according to this, from this table, we can see that these causes of low back pain, which is very much characteristic of spinal diseases or spinal disorders, can be classified as mechanical, okay, mechanical, non-mechanical, and visceral. So under the mechanical, we have lumbar strain. So lumbar strain, we can see that it consists of, like it's the most common are degenerative processes of the discs, facets, which are usually age-related. So, like I mentioned earlier on, to say that with older population, we tend to see more patients presenting to the health facilities, or rather to with these neurosurgical problems of the spine. Okay, so degenerative processes of the disc and facets, they tend to be more common with age. Then we also have herniated disc. We also have spinal stenosis. We have osteoporotic compression. We have spondylolisthesis, traumatic, like I've already mentioned. We also have congenital disorders such as severe kyphosis, severe scoliosis, and transitional vertebra. Okay, so it's very important also to take note of the term severe kyphosis, because remember we already mentioned that the cervical and thoracic vertebra, they tend to show that scoliotic kind of curvature. Okay. Then we also have other internal disc disruption or dysgenic low back pain. Then we also have presumed instability. Then under the non-mechanical disorders, rather spinal conditions, where these account for only about approximately 1%. So the most common are those which are mechanical, then followed by those which are non-mechanical. So under the non-mechanical, we have neoplasia. Okay, so we're looking at malignant and benign disorders of the spine. Okay. They may not really just be that of the spine. They could be also they could be primary or secondary anyway, or basically also affecting the spine. So other than neoplasia, we also have infection, which include osteomyelitis, septic discitis, and then we also have spinous abscesses as well as shingles. Then we also have inflammatory arthritis. Okay. So then we also have Paget's disease. Then the other causes of low back pain, we have visceral disease. Now, our concentration is not so much on that, but it's something that is important, especially when you're looking at when you're faced with a patient who has presented with low back pain, to be aware that they could also have a visceral disease. So these include disease of the pelvic organs. We can also have renal disease. We can also have aortic aneurysm, and also GIT disorders, or other diseases. Can go to the next slide. All right. So now let's look at these red flags that we're talking about. Okay? So the term red flags refers to clinical features. Okay? Clinical features that help to identify the presence of potentially serious conditions. Such conditions include tumors, infection, fractures, and neurological damage, which in this case is our main concentration. So screening for serious conditions must occur during history taking at initial assessment, and may be followed up with specific physical tests during examination. Okay. So now these red flags indicate the need to consider further investigation and or refer to the appropriate specialist. Now, what we're trying to say is that when we see a patient with these red flags, which we're going to mention, one, we should be able to know that this is a patient who's likely to have a very serious condition, and because it's a serious condition, it calls for emergency and prompt diagnosis as well as management of these particular patients. Okay. After that, after the investigation and initial assessment and all, these appropriate aspects be It could be an orthopedic kind of case where we need to refer such patients to the orthopedic surgeons, need to refer such patients to the neurosurgeons and such. Okay. Can go to the next slide. All right. So let's look at what are some of the clinical red flags that we can consider or that we can look at. So we have what is called the Cauda-Equina syndrome. The Cauda-Equina syndrome. So features of the Cauda-Equina syndrome includes some.
Sorry, John, can you mute Dr. Kabulo's mic, please?
Hello? Okay. So I was saying some of the clinical red flags that we can consider. Can we go to the next slide? So I think you've passed the slide that we're on. You can just go back. Okay, yes, right there. Okay. So I was saying some of the red flags that we can consider. We have what is called the Cauda-Equina syndrome. Okay. So features of Cauda-Equina syndrome include: one, we have urinary retention, fecal incontinence, widespread neurological symptoms and signs in the lower limbs. Then we also have gait abnormalities, saddle area numbness, and lax anal sphincter. Okay. Now, sudden loss of bile and bladder control can result from pinching of nerves to the bladder and to the bowel within the spine. Okay. Now, usually this is associated with a sudden loss of sensation in the gluteal areas and as well as in the legs. And we can also sometimes have weakness of the legs. Okay. So when these symptoms are as a result of pinching of the nerves in the lumbar spine, this is what is called the Cauda-Equina syndrome. Okay, and this is usually it is a true emergency if it appears to be acute. So acute Cauda-Equina syndrome is a medical emergency and requires urgent hospital referral. So it's not something that we need to waste time on. Whenever we see that it's an acute kind of development, patients presents with sudden loss of bowel and bladder control. They also present with gait abnormalities. They present with signs of widespread or generalized neurological symptoms and signs. They present with saddle area numbness and all. These patients need to be referred for further management by a specialist. You can go to the next slide. Okay, so other signs or other red flags of spinal disease, they include significant trauma. So, for example, those patients that are involved in road traffic accidents, okay, and there's quite some severe trauma to the spine. So these patients, such kind of trauma can also be considered as a red flag. Now, let me also mention that these red flags are not only limited to neurosurgery or to neurosurgical abnormalities. It can also be considered in other areas. Okay? Then we can also have back pain with unexplained weight loss. Okay? So these patients, when these patients present with back pain with unexplained weight loss, sometimes we could find that it's probably a malignant disorder. And these patients need to be evaluated and investigated appropriately. Okay? Because we understand that malignancy is very much associated with weight loss, especially if it's not something that has yet been discovered. So when we have a patient presenting with back pain with unexplained weight loss, malignancy could be one of those things that we can think about. Even things like Pott's disease, it could be some of the things that we can think about, because there's going to be, obviously, there'll be weight loss. Obviously, there could be other constitutional symptoms. Then we can also have the same back pain. Okay? Then we can also have history of cancer. So patients presenting with history of cancer, that can be considered also as a red flag. Then fever. This can be associated to several other many conditions, especially infectious diseases and malignant diseases. Then we also have intravenous drug use, okay, steroid use. Then also age is another important red flag. So if these red flags present at an age above 55, okay, if they develop at an age above 55, then that is a red flag on its own. Okay. Then we also have severe and remitting nighttime pain. Okay. So if we have back pain, which is severe and it cannot be remitted at night, then it is a red flag for spinal disease. Next slide. Okay. The other red flag is pain that causes the patient to be constantly moving or curled up in a sitting position. So if these patients are constantly moving or curled up in a sitting position, probably that could be a relieving factor in these patients. Okay, them being constantly moving and being in a sitting position. So when we see such patients, we should also consider that is a red flag. Then back pain that with constitutional symptoms, okay, such as fatigue, nausea, diarrhea, fever, also night sweats, okay, it can also be considered as a red flag. Then back pain that does not vary with activity. So I find that these patients, whether they are at rest or they are in some sort of activity, they are still having this particular pain, where probably the relieving factors are not even well known. Such is a red flag for spinal disease. Next slide. Now, there's a study that I came across. So it was a retrospective cohort study of 206 patients with acute back pain admitted from the emergency department, done by Nicholas Tobias Johans, Royson, and the others, on the reliability of red flags in spinal cord compression. Okay? So the presence or absence of the red flag symptoms was assessed against the evidence of spinal cord or cauda equina compression on magnetic resonance imaging, or rather on MRI. Okay? So these patients, they were assessed with MRI and they were found to have a spinal cord compression, and also they also had cauda equina symptoms. Okay? So they were assessed to see if these particular red flags that we're talking about, if at all they were reliable. So of the 3 symptoms routinely given as red flags for cord compression, the results from this study demonstrated that only 2, namely bowel or urinary symptoms and sensory disturbances, had a significant association with positive findings in MRI imaging. So what was found was that after this patient, there were those patients that were presenting with what are considered to be red flags, okay? And then they were assessed with MRI. So it was found that there was much association between these red flags and positive findings on MRI. However, it did not really mean that the others are not red flags, except that their reliability is highly doubtable, and mostly it calls for further investigation and evaluation of these particular patients. Okay? So their corresponding likelihood ratio showed that their presence in back pain had increased the risk of cord compression. So these urinary and bowel symptoms, including sensory disturbances, these had an increased risk. It means that these patients had an increased risk of cord compression. Next slide. So let's look at the approach. How do we approach these particular patients who are presenting with red flags of spinal disease? So if red flags are present, the following approach is recommended. Okay? So one, all patients with symptoms or signs of cauda equina syndrome should be referred urgently to a hospital for orthopedic or neurosurgical assessment. So especially if these symptoms and signs have developed suddenly, if it is an acute kind of development, then it is considered as an emergency. It is an emergency where we do not even have to waste time about. So these patients have to be referred to a hospital where they can receive orthopedic or neurosurgical assessment and management. Then patients with red flags should be investigated appropriately and referred to a specialist if indicated by clinical findings and test results. So there are other test results that can be done in this particular patient, depending on the condition that we're dealing with or that we suspect. So depending on the results that come out from that particular investigation, then these patients have to be sent or referred to an appropriate specialist. So investigations in an episode of acute low back pain do not provide clinical benefit, okay? Unless there are red flags, okay? So when you look at low back pain, we find that doing certain investigations will not really benefit the patient or even the practitioner. Unless if we have these red flags that we're talking about and want to rule out certain disorders like we have already mentioned. Okay? So radiological imaging such as X-rays and CT scans carry the risk of potential harm from radiation-related effects and should be avoided if necessary for diagnosis, if not necessary for diagnosis or management. So we're saying that it's not every patient that is presenting with low back pain that will require certain kinds of investigations, unless we see that there are these red flags. Okay? So the major reason, one of the reasons is that certain investigations like radiological imaging of X-rays and CT scans, they're going to carry that kind of risk to patients as well as the practitioner. Okay? So a full blood count and erythrocyte segmentation rate should usually be performed only if there are red flags. Okay, so from some of the causes that we talked about, some of the causes of spinal disease as well as those differential diagnoses for low back pain. So if we see those, it's not always that a full blood count and erythrocyte segmentation rate should be done, particularly for diagnosis of that. They could be done, especially a full blood count, because it's a baseline kind of investigation, but not necessarily to help us with investigating that particular condition. Okay, so it should only be done if we have the red flags. So other tests may be indicated depending on the clinical situation that we have. Next slide. Okay. So remember, red flag pathology may lie outside the lumbar region and may not be detected by radiology. Okay. So like we mentioned, we also have those visceral disorders, okay, such as GIT-related problems, so if we are to do certain radiological investigations, we may not be able to see any pathology in these particular patients. Okay? Now, one rule is that failure to improve, if these patients fail to improve after being referred to a specialist, and then they fail to improve, okay? So failure to improve after 1 month is a red flag, okay? And the patient can be referred back to the general practitioner for continued management and further diagnostic tests as required, okay? So the general practitioner will be able to refer the patient on to have X-rays, CT or MRI, blood tests, and nerve conduction studies. So if they are referred to a specialist, and then in the hands of that particular specialist, these patients are not improving in a period of 1 month, that is a red flag. And it indicates that these patients have to be sent back to the general practitioner so that there can be further assessment. And then after further assessment, they can be referred back to the specialist as needed. So it has been suggested that to reduce the rate of false alarms, the patient should be referred back to the general practitioner in the first instance to undertake further investigations as required before more advanced imaging is undertaken. Okay, let's look at the next slide. Next slide. Okay, so in conclusion, although red flags have a valid role to play in assessment and diagnosis, they should also be used with caution. Some guidelines contain no information on diagnostic accuracy for individual red flags. So we've mentioned a number of red flags, and some of these guidelines that may be used will not really show or give us enough information on the diagnosis, on accurate diagnosis of the disease. So it is the responsibility of individual practitioners to make themselves aware of these. Okay? Other guidelines even recommend immediate referral to imaging if any red flag is present, which could lead to many unnecessary referrals if clinicians did not clinically reason with their referral. So in the first instance, when we have these patients presenting with the red flags, it is important that the general practitioner or the clinician assesses these particular patients efficiently, okay? And in that assessment, including history, physical examination, and laboratory or radiological investigations that may be needed. And this is going to help us to avoid unnecessary referrals to several other specialists. Okay. So that is the end of my presentation, and those are some of my references. Thank you very much.
Okay, Ulrich.
Well, thank you very much for that presentation, Darwin. Unfortunately, I think Dr. Kabulo was not able to follow till the end. I'll first open up to everyone that has a question. Anyone has a question? Anyone feels like asking a question?
Okay, I have some question and observation.
Yes, go ahead.
Okay. Uh, thank you very much for the presentation, which was quite rich, but I have some observation. First of all is about your data. I think we should contextualize. We had data from the United States, but not really from Africa. So it's just an observation. So I think it will be better to have data coming from Africa. Other things, the about your red flags. Uh, okay, I propose that the red flag could have been rearranged according to the steps of of a medical observation. The signs would have been collected in an evolutionary way. Mm, and last of all, in terms of management, wouldn't it be preferable to first refer to a neurosurgeon rather than an orthopedist? I would suggest directly to the neurosurgeon, who is probably the last resort. So it's all. Thank you.
Well, thank you for those brilliant remarks. I would say for the last point, the red flags for the spine uh, can be for a number of diseases that necessitate integration of multiple specialties. So red flags for the spine interest as much as neurosurgery, orthopedics, rheumatology, ID, so infectious diseases as well. So I think we should just keep it to referral to the specialist, and then the specialist will be able to uh, move forward. And you gave a very valid point, which was when we talk about the red flags in a context, then the statistics, the data is a little bit different. We know, for example, that um, tuberculosis is very prevalent in our countries, and because tuberculosis is very prevalent, we have an equally high prevalence for Pott's disease. And when you take into consideration something like Pott's disease, uh, you wouldn't necessarily have the neurosurgeons running point on a case of Pott's disease. You probably would have the rheumatologist, and then with the infectious disease specialist, as well as the neurosurgeon, maybe an orthopedist, because again, spine surgery is not just for the neurosurgeon. So we should like integrate those things. But yeah, definitely, you made some really valid points altogether. So, and I agree with you that it is helpful even for Darwin himself, that when you have this information, although you've collected it, you've done a great, it's clear that you did some really amazing reading and you delved into some really interesting stuff. So when you get this, the best way for you to keep this information so that you can then be able to use it during your practice, your internships, or during your residency is like Dr. Regis just said. If you can organize them in the steps that you would do a clinical evaluation, it makes much more sense and it's more intuitive for you, because then when you're in front of a patient, you don't just cite, you don't just go like, oh, I read this, but you have that clinical thinking, right?
Okay.
Yes. And I definitely agree with him. That's a very, very much practical, pragmatic, and it helps you keep an eye on the important stuff.
Yes.
Yes.
Okay.
So
Thank you very much.
great job as always. You and I mean all the presenters for AFAN have always been fantastic, and especially Zolo and you, when you present, is always some good stuff. So it's clear that we have some good members here.
Thank you very much.
Thanks. Okay, so we're going to move on to our next presentation. Our next presentation would be by Zolo Ivan. So we'll have another round of presentations and then we can start. I'll start. So I'm Ulrich Sidney. I'm the president and founder of the Association of Future. Oh, Dr. Kabulo is here before we go, because Dr. Kabulo was really interested in this presentation. I think he will have something. Unfortunately, he wasn't able to follow all the way to the end, but I'm sure he has some valuable input. So Dr. Kabulo, Dewin just concluded the presentation, and if there was any comment maybe or points that you feel we should keep in mind that you want to share, please.
Thank you so much, Dr. Ulrich. Unfortunately, I had also network problems. At some point, I didn't follow properly. What I wanted to say, it was a very great presentation. He highlighted almost the important things. So what I wanted to add to Darwin is about etiology. He mentioned trauma, congenital, inflammatory, hereditary, degenerative. So he should also add metabolic, vascular, and also infestation. I don't know if he mentioned also neoplastic. Then another thing I saw, he said acute Codequina syndrome is a medical emergency. No, it's a surgical emergency, not medical. So otherwise, it was a very great presentation. Thank you so much, Dr. Darwin.
Thank you very much, Dr. Kabulo.
Yes, and that comment by Dr. Kabulo is very, very important, especially for those of us trying to get into neurosurgery. You need to be able to recognize those neurosurgical emergencies for the spine, and definitely Coder-Equina syndrome is definitely a surgical emergency. Fantastic. So we'll be moving on to the next